Hello. Are you sitting comfortably? My name is Dr. Henry Murphy. You may remember me from such talks as back pain, watch out, or observation bay, watch out. But today we're going to be talking about anaphylaxis. So, anaphylaxis is a major cause of preventable death, especially of young people, and we can try and help in emergency medicine prevent morbidity and mortality in that patient group. So a little bit of knowledge goes a long way, and what we'll do is cover the definition of anaphylaxis, the common triggers, differential diagnoses, management and follow-up, very, very briefly, just to give you a quick refresher. You may have lots of prior knowledge about managing anaphylaxis, and it's important for us to make sure that that matches the way that we do things here in West Middlesex. So, anaphylaxis is defined as a severe, life-threatening, generalised or systemic hypersensitivity reaction. So not necessarily an allergic reaction. And it's characterised by rapidly developing life-threatening airway and or breathing and or circulation problems. So the onset's usually sudden, and it's often associated with skin changes, so a rash or urticaria, and it can be associated with other symptoms like vomiting. In terms of the order of frequency, the triggers are as follows. So stings from insects, etc., nuts, other foods, and then drugs. And it's why it's essential for us to talk about allergies in our histories with patients. And then the last group of patients is idiopathic or sort of other causes, which is why we don't classify anaphylaxis as just an allergic reaction. In terms of differential diagnoses, obviously somebody presenting with breathing problems might make us think about asthma, especially if they have a history of asthma themselves. Patients can present with tachycardias, low blood pressures, rashes, so we're thinking maybe sepsis instead. Urticarial reactions can sometimes be diagnosed as anaphylaxis, and later on we confirm that actually they weren't. The way that the patients present might be very anxious, very concerned about their breathing, so panic attacks are a differential diagnosis as well for people who don't quite have all those criteria. If in doubt, get some help, but maybe also get the adrenaline that you're going to be using to treat anaphylaxis ready, because if in doubt, it's always worth discussing with the registrar about whether it's beneficial to treat if there is any doubt at all. In terms of management of these patients, so we want them in an area where they can be seen and they're visible. They're not going to be off in a cubicle or side room somewhere that isn't visible. We're going to be wanting somebody to stay with them, and we're approaching them for an ABCD approach. So in terms of airway, thinking about hoarseness, inability to speak, sore throat or throat tightness, stridor, apnea. For patients like this who present with airway problems, we're going to be calling for help early. So the registrar in charge needs to be with you, and you're going to be thinking about calling for help from the anaesthetic team. In terms of breathing problems, the patients will be complaining of maybe chest tightness, they might have wheeze, they might be tachypneic, they might have low saturations, they might seem cyanosed. In terms of circulation problems, they might be complaining of dizziness, they might be unconscious, potentially, because of hypoperfusion to the brain. They might be tachycardic, pale, edematous, like we said, hypotensive, and the end sort of presentation of these patients might be cardiac arrest, and we've seen that before here at the West Middlesex. Obviously, we're going to be trying to prevent patients from progressing to cardiac arrest, and so the only intervention we want you to think about initially is IM adrenaline. So people get very confused about adrenaline, about the concentration versus the volume versus the dose. So in adults, we're talking about 500 micrograms of IM adrenaline, not intravenous. That's not a treatment that we would use in ED without some specialist help. And the concentration would be 1 in 1,000 because it's a smaller volume, okay? And that's intramuscular. We shouldn't use the EpiPens that patients present with, partly because that's their own EpiPen, but also the dose is normally smaller, and also we know that our IM needles are big enough to get into the muscle. If we've got access to IM adrenaline and ampules of 1 in 1,000 adrenaline, we should be using. Other interventions that you might be wanting to use are dependent on the patient's condition, but it's normally a good idea to put on oxygen early, so high flow oxygen. You can give intravenous fluid to try and help prevent those third space losses, and then chlorphenamine and hydrocortisone can be helpful, but all of those other interventions aren't the life-saving initial intervention that we need to be thinking about in anaphylaxis. That's adrenaline. Regularly reviewing the patient after they've had adrenaline is really important, because some patients can continue to need more, so we can give adrenaline every 5 minutes. Also, once patients seem to recover, some patients experience another reaction, or a biphasic reaction, and that's why we try and observe these patients for at least 6 hours after their initial dose of adrenaline. If they've had one single event and 6 hours is fine, we can normally discharge them with some advice about returning about any red flag symptoms, and also about seeing somebody about confirming the diagnosis. If they have a biphasic reaction, then it's normally worth referring them into the hospital and to the medical team. Secondary to the management of anaphylaxis, if we can, it's worth sending a mast cell tryptase sample, which is a blood sample, 1 or 2 hours post the reaction, to try and confirm that this was definitely an anaphylactic, not a, say, urticarial reaction. That's great for the patient's follow-up. It's obviously not going to change the management at the time, but if we can, it's really important to try and do that. So, in summary, anaphylaxis is life-threatening. It affects everybody, especially young people, and it can be fatal, and it's really important for us to try and make sure that we diagnose patients, get help early, and treat early as well. Thank you for listening.